Hi everyone, my name is Julia Mayetta. We are so pleased that you all could join us for this week's lecture in Volume 6 of our No Neuropsychology Didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of our rotating committee. Before we start, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel, so be sure to check it out, subscribe, and like our lectures to get first access to new content. New to No Neuropsychology is our collaboration with APSIN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APSIN as well. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions, here are the disclaimers. Questions can be submitted via the Q&A box on the lower left of your screen, and we'll be providing a recording of today's lecture on our website and YouTube channel. Now, it is my pleasure to introduce Laura Campbell, Dr. Shefali Singh, and Dr. Laura Umfleet for today's lecture titled Incorporating Technology into Neuropsychological Assessment, Digital Tools for Tomorrow's Practice. Laura Campbell is a doctoral candidate at the SDSU UC San Diego Joint Doctoral Program in Clinical Psychology and is completing her predoctoral internship at the Charleston Consortium. Her research interests include integrating digital tools into neuropsychology research in order to improve efficiency and ecological validity of neuropsychological tests, as well as examining the dynamic associations between cognition and modifiable lifestyle factors in the real world. Her clinical interests primarily focus on neurodegenerative disease and cognitive rehabilitation, and she hopes to continue to integrate technology into these clinical settings. She is the ANST Neurotechnology Officer and also serves on the NAN Student and Postdoctoral Resident Committee. Next up is Dr. Shefali Singh, who is a licensed clinical neuropsychologist and director of digital cognitive research at Harvard Medical School and McLean Hospital's Institute for Technology and Psychiatry. She is a lecturer at Harvard University where she teaches courses related to technology and mental health. And on the business side, Dr. Singh is a venture associate at the venture capital fund Athelion Capital, where she invests in digital health companies. Dr. Singh also holds leadership positions in APA and SCN and serves as president of Division 12, Section 10, as well as is the founder of the ANST Neurotechnology Initiative. And last but not least, Laura Umfleet is a board-certified neuropsychologist and associate professor of neurology in the Division of Neuropsychology at the Medical College of Wisconsin, MCW. Her background includes research investigating psychometric properties of the Wechsler scales and other neuropsychological measures in patients with neurodegenerative and other neurological disorders. Current research interests include application of contemporary technology and psychometric approaches to neuropsychological assessment, as well as investigation of early biomarkers for Alzheimer's and related diseases. She is the MCW site PI for the NIMH-funded National Neuropsychology Network, which we'll hear about today. So without further ado, I will pass it over to Laura Campbell to get us started.
Great. Thank you so much for having me today. I'm going to be talking about dynamic associations between lifestyle factors and cognition that we examine using wearable devices and smartphone assessments. I'm going to give kind of a broad overview of different technologies. I'll give one example research study we have, and then kind of some general thoughts on use of technology, as well as answering a lot of the questions we get with some of this data. I will preface this with this has an older adult spin to it, but a lot of these concepts can be applied to a lot of different populations. So first, EMA, I'm going to guess many of you know what EMA is, but it essentially allows participants to repeatedly report on their experiences in real time, in real world settings, over time and across settings. So we can get a lot of information in a real world setting. Building upon this and integrating objective measures into EMA, we get ecological momentary cognitive testing. So these are frequent, brief, and repeated self-administered mobile assessments of cognitive function conducted in everyday life settings, and have shown to be a promising complementary tool to traditional assessment approaches. I have a few featured here that I'll talk about later. The one on the left, probably most of you noticed, this is a Stroop-based task, so it's measuring inhibition or executive functioning. And then the two on the right are a verbal learning test similar to a CBLT. However, participants read the list of words 3 times and then auditorily respond. And these are taken in everyday settings. In a systematic review, they've shown to be pretty feasible, so about 80% adherence rate. Of course, participants are usually compensated for their time on these. And they've also shown pretty good convergent validity with lab-based testing. This is, of course, of published tests. There are a number of companies out there that have similar type assessments that are not well validated, but of those that are validated, they show pretty good validity, but that is just kind of a disclaimer of be sure to check that there is actually studies backing up the science to these tests if you want to use them. So why might we want to use these? So I think, as we all know, in traditional neuropsych testing, we usually only see somebody at one time point, or we may see them at one time point and then months to years later. However, there's definitely some noise and variability in how somebody does. So maybe on the first time you see them, they do a little bit worse because they haven't slept well, they're pretty anxious. But then at follow-up, when their average actually has changed and they have declined, we catch them on a better day. But due to that noise, it's hard for us to pick up on the change that has actually happened. So repeated testing may be helpful to establish a better average baseline and then potentially detect subtle changes. There's a number of other pros to this approach. This approach could be potentially more ecologically valid. I think many of us know that these tests don't always, or many of our neuropsych tests don't correlate well with everyday functioning for a number of different reasons. And everyday functioning is very complex to measure, and there's a lot that goes into it. But because these are taken in a participant's everyday environment, they potentially could be more ecologically valid. And what I'm going to mainly focus on today is how we compare EMA, ecological momentary cognitive testing can be paired with other devices to start to look at dynamic associations. There are some cons that I've listed here. There's going to be cons with every sort of technology, from taking it in a non-standard environment to ethical and privacy considerations. But overall, I think this is the pros outweigh the cons. I'm going to briefly just touch on why we also want to be looking at objective and subjective lifestyle factors as well. I'm particularly interested in lifestyle factors as a way to intervene to potentially improve cognition or stabilize cognition. When we assess lifestyle factors, many research studies use self-report, and self-report on a lot of lifestyle factors is found to be pretty discrepant from objective measures. So for example, sleep in older adults with insomnia generally underreport their sleep. Older adults without insomnia actually generally overreport their sleep. So there's a lot of discrepancy there. And while somebody's subjective experience is very important and it's something we want to understand and gather, getting that objective data is also going to be important in understanding these different lifestyles and how they associate with cognition. In terms of subjective cognition and everyday functioning, I think we all know this can also be biased. For example, in older adults, there may be limited insight or agnosia that's going to bias cognition and self-report of cognition and everyday functioning. A lot of times we rely on retrospective recall, say, in the past month, how have you been doing? And this is particularly problematic in groups of populations we work with memory or executive functioning deficits. We also know, particularly in older adults, psychiatric factors are often found to be more associated with subjective functioning. So again, while subjective cognition is really important and measuring everyday functioning is really important, integration of technology may help to kind of bridge the gap or reduce some of those biases. All right, so overall, what we found is that ecological momentary cognitive testing can be paired with other devices such as EMA or other sensors to provide us with more accurate information and more information as well. With more information, we can start to look at variability. Using frequent assessment like EMA, which is less reliant on retrospective recall, we also may be able to look at more accurate information as well as variability. So I'll be talking about this mobile cognitive testing paired with EMA and an actigraph watch, which I have here. But this theory can kind of be taken and applied to a lot of different technologies. Like I have the keyboard there because people are starting to look at keystroke dynamics. There is a sensor there that looks at medication. There's a lot of different sensors that we can put in people's homes now to better look at everyday functioning as well. So ultimately, we can integrate these technologies to learn more about the dynamic associations between several different variables and cognition and everyday functioning. I'm going to highlight one study in particular. So this was a study by my mentor, Rayanne Moore. It looked at people with and without HIV over the age of 50. They were seen at 3 different visits. Their baseline visit, they received questionnaires and comprehensive neuropsych testing. They were given and trained how to use the smartphone. So for this study, we gave participants smartphone devices, even if they had one. There's always kind of the debate of, do you give the device or do you use the person's own device? And there is pros and cons to both approaches. And then they were also given the actigraph watch, and then they took part in a 14-day EMA study, and they were compensated for their time. You can look at their demographics here. We kind of have a range of people. The main thing I want to highlight with this is that while the majority of people did own a smartphone and had used smartphones before, not everybody did. And so even those who did not own a smartphone, did not regularly use a smartphone, were still able to take part in this study. And this is because the application on the smartphone device that we gave them is pretty simple, but they also had a training to that. So I think this really highlights that with training and with increasing confidence in technology use, people without these devices can engage in this research as well. So the study I'm going to highlight is this one here. For this study, we looked at the within-person relationship between subjective and objective sleep. So for subjective sleep, we asked them via EMA, so how much did you sleep, how restful was your sleep? And then for objective sleep, we used wrist-worn actigraphy, like the watch I showed earlier. We then looked at cognition the next day. So we looked at subjective cognition and objective cognition. Subjective cognition, we asked about forgetfulness and difficulty concentrating. Objective cognition, we had them take those 2 mobile cognitive tests I showed earlier, and then we had a series of mood questions. Here's kind of an example of those EMA questions I showed. We also, again, gave them some mood questions. And I'm not going to show the figures. I do encourage you, if you are interested in that study, to go more closely look at the paper, but I just want to highlight the conclusions and why this is important. So first of all, we found that subjective sleep and objective sleep were highly correlated. And so this is actually different than the literature. So if you give somebody a questionnaire like the Pittsburgh total sleep time, average total sleep time, is often not correlated with somebody's actual total sleep time. But here we found when we asked the person in the morning, we're not relying on retrospective recall, they actually did pretty good. So this shows that if you don't have the actigraphy watch, you could ask this question via EMA and get pretty good results. We then found that subjective and objective sleep were associated with subjective ratings of cognition. So people who slept less, it was less restful, both subjective and objective sleep. It was associated with more feelings of forgetfulness and more feelings of difficulty concentrating. It, however, was not associated with those objective measures the next day. And so, we're only measuring inhibition and we're only measuring learning. So there could be other things going on there. We have found within day associations with these measures before. So this may indicate that total sleep is really associated with subjective experience. We found that worse subjective sleep was associated with next day decreased happiness, greater depressed mood, and more pain. And then we found, interestingly, that greater objective sleep, so over 8 hours as compared to 6 to 8 hours, was associated with worse depression the next day for that person. And then less objective sleep, less than 6 hours, was associated with feelings of worry. And so overall, these effect sizes were pretty small. We would kind of expect that. We don't expect these drastic changes within day, but this study really does demonstrate that we can start to look at these dynamic associations, and that may be meaningful for looking at these dynamic associations and then applying them to interventions. So the implications of this research in general, so these methods may be useful for detecting cognitive change and dynamic associations. With older adults, if we have a better baseline on somebody, we're getting more frequent assessments on them, we may be able to detect subtle changes earlier, and these would be within person changes, and we may be able to detect better change over time. So is somebody improving over time, stable over time, and things like that. I say may because, well, I think there's a lot of promise to this. We haven't actually proven that quite yet. This research also could be used to inform interventions. And so this is where I'm really interested now. And I think some people are starting to integrate these technologies into interventions. But in theory, if somebody does this, we could provide them with more personalized feedback, like, hey, it looks like at this time of day, you're more cognitively alert. Let's have your more cognitively taxing activities at that time point. And then we may be able to use it as, looking at the correlations within that specific person to provide more individualized interventions. Because that's a lot of work on a clinician and the participant, I don't see that working as much, but if we can gather enough data and get enough data points to understand, in these types of people, these lifestyle factors seem to play a larger role versus as opposed to other lifestyle factors, we could then take that data and hopefully apply it more to individual people. And then technology also allows for real-time interventions as well. So while this hasn't been done as much, it could be integrated to within week, in between seeing a therapist, technology can kind of prompt a person, help with potentially everyday functioning or sleep regulation and other things like that. There's a lot of research that still needs to be done. More research on this is needed in general. I think we also need to be thinking about, what are we going to be doing research-wise versus what could we eventually integrate clinically? And I think with that, we need to be thinking about how time-intensive these things are, and what are more passive ways we can collect meaningful information. So passive sensors, other passive technologies that can give us a lot of good information, but doesn't require as much active participation. I think another thing that we've struggled with is the best way to validate these methods. So a lot of times we gather a lot of data, and so it's kind of weeding through, of this data, what's most meaningful, what's the most validated and reliable data that we gather if a technology produces, 100 different types of data. And then I also think because we're kind of repeatedly sampling people and, we are in theory potentially getting a better average for the person, we need to be thinking about how we actually want to be going about validating these measures rather than maybe relying on traditional psychometric approaches. But I don't think we've quite figured that out yet either. And then my last point that I'll highlight is that this research really needs to be multidisciplinary. With this, I think neuropsychology can bring a lot to the technology field, but focusing on, in terms of neuropsychology, what do we bring and how can we partner with engineers and speech language pathologists and data scientists to really bring our expertise in. All right, so that is what I'll say so far. I have a lot of people to thank and co-authors, participants, and our support.
Thanks so much, Laura. Dr. Umfleet, would you like to go next?
Yes. Let's see here. All right, I think that's working now. I'm just going to go ahead and get started with this slide. That was an excellent talk, Laura. I think that you're forward thinking, and that's where our field needs to go. And so I want to focus on the integration of technology into clinical practice, which is really a primary goal of the National Neuropsychology Network. Is take a bit to think about where you're at in your training and the site, your site and the practices at your site. And you're probably still using a lot of paper and pencil administration. Maybe you're using Q Interactive technology. Our tests are old, and based off of classical test theory, there are modern or more contemporary methods that we can use. And the focus is on diagnosis and prediction of treatment response. And then you have your data summarized, and maybe a data summary sheet goes in your report, then you put it in your medical records. And then if you're doing some research, you have these local data banks. And databases are great, but there's inefficiency and redundancy across sites that are collecting neuropsychology data as part of clinical practice.
Dr.
So,
sorry to
can you hear me?
interrupt. Yeah, sorry to interrupt. I don't think we're seeing your slides.
Really? It's all in presentation mode. Sorry about that.
No problem. Do you want to try and reshare your screen?
Yeah. Is that showing?
Yeah, I see the PowerPoint. Perfect.
Oh,
Thanks.
yay. Good. Sorry. All right. So a lot of us are doing paper and pencil administration, and then we're using homegrown scoring programs, some better than others. We have these big batteries of tests. Like you can think of different patients that you're, doing an 8-hour assessment with. Well, why do we really need to do that? How short can we make our evaluations without compromising the reliability and validity of our measures? So we need young minds like Laura and others who are leading, the technology piece. We need to create a network of like-minded individuals interested in moving forward the field of neuropsychology. We have the knowledge in neuroscience, neuropsychological measurement, and human psychology, but how are we positioning ourselves when it comes to leading edge technologies? And we need to think big data. We collect so much data every day during a single clinical visit. We need to think of ways to capture those data. And what if we could capture all of those data in clinic while we're with a patient? That would be huge. And so might be a good place for us to start to merge the technology piece that is way surpassed where neuropsychology is now, but to kind of get us up with rapid advancements so that we can keep ourselves relevant. I'm not saying that technology is the only answer, but clearly there are some really cool things that are out there and we can do so much better. And so I think it's a combination of technology, but also making sure that we're still able to do things if for some reason technology crashes. So, you got to think, this is something that Bob Builder, who put together the slide like many years ago. And he, just thinking through like, what could our future look like in clinical practice? Wouldn't this be fantastic if you could take in the omics era that we could start to have genomic data, we could have our neuroimaging data, we could have our cognitive data. And then you can kind of get this, kind of dashboard, kind of a diagnostic dashboard that kind of helps you then be able to better diagnose people. but also collect some useful information to be able to use your data, your cognitive data, with stuff that's from the clinical records. And we're getting biomarker data that's going to become clinically available on a regular basis. It's coming. So I think that, being able to integrate our data with that is going to be huge. Bob Bilder and Steve Reese published this paper a few years ago to kind of, just start the conversation of how do we get to where we have been stuck in for so many years to the future. And in that manuscript, you can look and you can see the current practices of what we've been doing for decades. And then you can see some, potential future suggestions for what we could do and how that could put us at an advantage. And also talking about, wearables, mobile platforms, Internet of Things, healthcare informatics, bioinformatics. We've got to start thinking about all of these mechanisms that can really help launch us and make us better and make us be able to help our patients even more. So Bob decided to put together a team and put an R01 together. And so the National Neuropsychology Network was created to try to really kind of help the interface of technology and clinical practice. And so there are 4 sites currently who are actively participating in this. This is hopefully soon to be expanding. And we are working with someone from Pearson, Dustin Wallstrom, and that they've been helpful on the QI technology piece, but they don't have any voting rights or anything like that. I initially myself was skeptical, thinking that we're working with Pearson, a big test publisher, and I have been surprised by how wonderful and how collaborative they have been. We have to have statistical expertise. So Steve Reese and Keith Whitman are our IRT whizzes. And then we have Stone, who is doing the programming and doing a fantastic job with that for our different technologies that we're developing. So I thought we would start with most commonly administered tests across sites. And you can see that most of these tests are also part of the Rabin et al. Study in 2016 that shows that we all kind of give the same thing. So we're trying to collect data on over 10,000 cases, or at least 10,000 cases across sites. And the inclusion-exclusion criteria is very broad. These are patients who are just coming in part of their clinical evaluations. So you are going to get differences in terms of what tests are given and what presentations you're seeing, but we're trying to, be quite inclusive and representative of the patients whom we serve. Currently, or up until September 20th of this year, when I pulled these data, we are on track to achieving our 10,000 target. And you can see here that, which is not surprising, I would bet, but that our representation of non-white individuals is lower, and we're trying to improve that with our future grant, where we hopefully will be successfully funded for the extension of this project. So out of this project, we hope that you can do more evidence-based battery selection. Why give all of these tests? Do you actually have to give this next test, or do you have enough information so you can make a proper diagnosis? Maybe we can put together some computerized adaptive tests too. Fix short forms if you can't do computerized adaptive testing. And then look at and analyze the data that we get, hopefully to kind of help with new measure development. But we also want to create a platform to enable future measures, such as the one that Laura was talking about, and others that are just stuck in the research, and we want to make it where it's actually usable in clinic. And having the infrastructure for that is part of this grant. I'm just going to briefly touch on the different technologies. I know for time's sake, I'll rush through this pretty quickly, but I'm happy to discuss more. So we have the structured history protocol for neuropsychology, and this is taking your clinical interview you do that probably is quite similar across the different sites that you're training at, or you've been at, or you're conducting your own interviews. We have common data elements that we're collecting. We just aren't collecting those common data elements as part of our clinical practice. So Lucia Kavanaugh got a grant to build the SHIP-NP, and this is taking our neuropsych interview and putting it in kind of a standardized format, but also it's empirically grounded. So she's integrating different CDs from other initiatives and looking at different common data elements for different aspects, like such as medical history and family history, and looking at DSM-5 cross-cutting measures, different quality of life measures, and then getting the World Health Organization disability assessment schedule. So that's kind of a rating of percentage of disability. We did include an optional questionnaire for COVID anxiety or worries, but this is a way to kind of integrate some standardized approaches and as part of the clinical interview, while also capturing parts of the assessment that we will ask, such as like, oh, tell me about your cognitive concerns. So it's a standardized way to do that as well. And this is something that's been integrated into clinical practice, and I can speak to specifically my experience with this. And what you're getting from this kind of smart form questionnaire that's our clinical interview is there are a lot of questions, and it's using the smart logic, so you won't get certain questions depending on what your prior response is you can get your clinical interview pretty much ready to go in narrative format, or if you want it into tabular format with all the common questions that we're asking as part of our clinical interview. It's populated there in electronic format. You can just copy and paste it into your report. It's crazy easy. And then sometimes, it's asking questions that you may not think to ask when you're interviewing certain individuals. Maybe like if you're interviewing someone who might have mild dementia, you might not start asking a whole lot of questions about developmental history. It'll cover different things that are nice to be able to look at. And it has an inclusive way of asking information, which is really nice too. So part of this grant also developed kind of this platform for where we can start to, capture data on measures that we already give, but also this will be a platform for novel measurement. And so we are using Q and Active. They've done a really nice job with capturing a lot of item level data for commonly administered tests, but they don't capture everything. So then we built this platform that we're calling Sailor. And that's going to be capturing a bunch of other measures as well. And this is kind of showing people the workflow. So you can see, I don't know if you can see my little cursor here, but this is showing, where you have the technologies here, and this is going to the Pearson servers, which then gives you back your information that you need for your clinic. Then the flow of the data can go through the Pearson servers into the UCLA server where the Sailor and the other technologies are. And then it goes into a national data archive. So we're collecting item level data of all the measures most of the measures that we're giving as part of routine clinical practice. And we're able to do this without, release of private health information too. So we have a specific ID process that goes through this. It's super slick. It's super easy. And we're hoping that this will be in good shape in the upcoming years. Here are some of the measures that are included on the NNN the testing app, and the SHIP-NP is also on this as well. And again, it's taking all these things and making them easy to administer and capturing item level data. So this is just to basically emphasize that this process has been a humbling process. There are multiple steps, as you know, with trying to develop technologies. That it's not just boom, it's ready to go. It's easy. It takes time. And so there's a process of getting through the IRB, being able to get things set up from the technology perspective, building the technology, getting an ID identifier methodology down. We were able to get IRB approval for waiver of consent, which was super huge for collecting data. And now we're in a phase where we're integrating the SHIP-NP and the Sailor technologies into clinical practice as well as Q Interactive. And this is to basically just show that at MCW we have an insanely busy clinic with faculty and trainees and psychometrists and practicum students. And it's been a journey, but we have really come together as a clinic to be able to integrate these different technologies and to move forward with the other national neuropsych sites to help improve what we do and to move our field forward in the modern era of, well, soon to be more modern, but we need where we can integrate the technology into clinical practice. So we've successfully created a standard for item level data capture. And as the NNN expands through addition of new clinic sites, Sailor will serve as a model for future neuropsych research collaboration by allowing access to NNN methods, test procedures and software, and archived data. And we hope that this infrastructure will rapidly propel future projects that will establish a concurrent and incremental validity of diverse novel assessment measures. So the next steps were currently under review for renewal, where we're going to expand elements of the technologies to include both English and Spanish. And then we hope to add other languages over time. And we think that this network could serve as a model for international development as well. And we think that this will be great for us to look at different methods for improving the psychometric properties of the measures that we give. An ideal, it would be that we can have a global bank of methods to share freely and be able to benefit from each other, such as like different networks such as Enigma, if you think about that, or ADNI, where we're all coming together to learn from each other and to be able to improve the measurement that we use and to help our patients. And the other thing, if you're interested, for students, I know there's a bunch of special interest groups, but we are, kind of an extension of the National Neuropsych Network is the INS Worldwide Initiative for Neuropsych Data Sharing. So if people are interested, please shoot an email to that email address there.
Thanks so much, Dr. Umpley. Dr. Singh, do you want to share your slide?
Yeah, I was just, do I only have 3 minutes to present, or how long can we go?
Oh, you can go as long as you need to. We'll have a little bit of time for questions at the end.
Okay, great. I just wanted to make sure. Let's see. Okay.
Looks like we're seeing a really zoomed in view.
Yeah, let me fix
Okay.
it here. Okay, can you see it okay?
Yeah.
Okay. Is it like the full screen that?
Yep, looks good.
Okay, perfect. Okay, so I will run through this as fast as I can, but essentially my research is looking at implementing digital tools in neuropsychological evaluations. And so, as we know, neuropsychological testing is really sensitive to detecting impairment, but not necessarily specific. There are a lot of problems establishing ecological validity in that, we're assessing our patients in a controlled environment and really only getting a single time point of evaluation. Our tests themselves have huge limitations in terms of normative data. They're race and culturally biased, and may not be suitable for the ages that we're assessing. For example, if you showed this picture to someone in Gen Z, I don't think they would know what it was. So our tests themselves are outdated. And I put this together in one of our papers from last year, but essentially this is just a list of the most commonly used batteries. And as you can see, They range from the 1940s, that the most recent one being in, the newer CVLT version. So our tests are old. And so my big research question is sort of like, how do we fill gaps in neuropsychological evaluations so we can acquire more ecologically valid and accurate data on an individual's cognitive functioning? So my first few questions that I asked is, first, can we digitize our existing neuropsychological tests? And if so, what are potential limitations? Is psychopathology a limitation, or psychological symptom severity? Is method of test administration itself a problem? And so my dissertation actually was looking at just effort testing and depression, anxiety, impulsivity measures, and then executive functioning. And I was comparing sort of the difference between computerized and manual test administration of the Wisconsin card sorting test. And for time, I won't go into too many details, but essentially, I found that there were 2 times the number of failures to maintain set on the computerized versus the manualized version of the Wisconsin, and their interaction effects within the computerized administration, in that a lack of perseverance yielded an increased failure to maintain set in the computerized administration. And then the manual administration, we found that increased positive urgency yielded an increased failures to maintain set, about 2 times as likely. So we can't use the same normative data for digitized versions of traditional tests. And so psychopathology and psychological symptom severity are potential limitations of digitizing existing tests, as well as method of test administration itself. And that's what really got me interested in digital neuropsychology. And this is the idea that we can assess cognition using digital tools. We have computers, we have smartphones, we have tablets, we've got wearable devices. And this is not to say that we need to completely substitute our traditional paper and pencil assessments with technology-based tools. Rather, it's this shift towards incorporating sophisticated models of behavior that actually capture everyday behavior in ways traditional measures can't. And so with the COVID-19 pandemic, we had a huge accessibility issue within our field, which sort of demonstrates the fragility of our paper and pencil measures in a big way. And so what our lab did was created the Test My Brain Digital Neuropsychology Toolkit, which some of you might have heard of. And it's based on our normative data with over 12 million people around the world. So huge sample sizes, but not validated in a clinical sample. And clinicians can choose among these different tests, and then they're given a specific ID code that's sent to the patient, and then you can get the results. And so this is kind of how it looks. You just click this, and then it'll give you an estimated time. And then you can look up Z-scores in our normative tables. So in a pretty granularly, and you can look at a lot of different types of scores. And this is just an example of some of the types of measures that we use. So some of them are pretty similar to our traditional neuropsych assessments. So what we found is, 500 new batteries are still being created per month. Most people that use it are clinicians, which isn't surprising, but it sort of demonstrates the need of clinicians for digital tools to assess cognition, particularly in the beginning of the pandemic. Our tests actually, when used in that setting, showed good internal reliability, and they correlated highly among the cognitive domains that we expect. So the next question, for me, was how can we improve and develop reliable, valid, and accessible digital assessments that will be actually accepted and used in neuropsychological evaluations? We've all kind of talked today about tools that we have and ways that we might be able to use them to assess cognition, but how do we actually get them used in our clinics? Clinicians and by and large are often hesitant to adopt non-traditional assessments, which makes complete sense because they're not validated a lot of the times on clinical populations. And they can also be expensive, and we're not exactly trained on it in graduate school or fellowship. So resuming in-person methods, in-person assessment might lead to reversal of to old methods. And so what that means is that, now that we're sort of getting out of the pandemic, are we just going to solely use our old methods of administration, or can we use this as a way to poise ourselves to use more digitally advanced assessments? And then how can we selectively preserve the effective parts of digital neuropsych evaluations? And so I coined this term hybrid neuropsychology, which is applied digital neuropsychology in the post-COVID era. And it focuses on clinical integration of digital tools in addition to standard methods of cognitive measures of cognitive functioning. And the idea is that this would allow neuropsychology the opportunity to scale, promote healthcare equity and access, monitor short-term changes or fluctuations in cognition, primarily through ecological momentary assessment, and evaluate state and context-dependent neuropsychological functioning. And this is an example from our lab where we're looking at glucose monitoring. We're looking at glucose levels, and we're looking at specific cognitive tests that we have and their performance. And the idea behind this is that you can see that there are both in between and so intra and inter individual differences that we can monitor over time using EMA. And this shows you that, people, if you aggregate scores across, you're missing a lot of nuanced, really rich data. And so like Laura have mentioned before me, continuous monitoring is a great way to sort of capture that unique data. And so hybrid neuropsychology sort of promotes 3 action items, which is developing a technology-based practice, integrating data science, and then engaging with innovators in other fields. And so by developing a technology-based practice, it means sort of incorporating a lot of digital modalities when collecting patient data. So the benefits of this are timely delivery, more increased precision and accuracy. But a huge barrier that we're facing now is sort of the validity of novel digital tools and sort of this hesitation to adopt innovative technologies within our clinical practice. So the best way, I think, to do that is sort of cross-validate new tools with traditional tests and ensure validity of these tests through empirical studies. And one example of the types of tools that we can use, I love this paper by Justin Miller and Bill Barr, in that, it's one of the really great ones to sort of integrate a lot of different digital tools, hardwares, and software that we can use as a proxy for cognition. And then barrier 2 is just sort of integrating data science by aggregating data that's collected across patients in multiple modalities. And the benefit of this would be improved methods for accessing, storing, and sharing patient data. So the NNN is a great example of this, increasing greater consistency and integration of data points across clinics. And there's more sort of straightforward development of a national repository and new tests. The problem that I see with this is that, not all of us are data scientists, right? And so being able to incorporate this in an efficacious and sustainable way might be difficult. And also reaching consensus regarding types of data management tools to use, right? Because, and being able, and sort of the bottleneck being training to use those tools. And so I think the best way to sort of address that barrier is collaborating with individuals in information technology and data science, and just increasing communication regarding best practices. And this will be especially important because as our field sort of continues to, oops, I skipped something. Okay, well, this will be particularly important because, we have to sort of focus on ways that we validate our tools. And so one thing that we're doing right now at McLean is this project called Digital Neuropsychology at McLean, where we're first cross-validating traditional and our Test My Brain cognitive tests in clinical samples and looking for patterns captured through digital responses that translate to specific cognitive and mood, actually, or cognitive impairments and mood. And then we can sort of better assess performance validity as well, which is the third goal, which is determining cutoffs for identifying inconsistent response patterns and cross-validating our data with standard performance validity measures. Because I think a real strength of using digital tools is their ability to better assess our performance validity, because they can measure that reaction time and fluctuations in reaction time much, much better than we can. And they might be more predictive of variable attention or engagement than we are currently. And then finally, the third action item would be engaging with innovators in other fields by collaborating with leaders to develop, share, and implement new digital tools. So The benefits would be a better integration with technology-based fields. As someone who's in venture capital and, starting my own, tech-based company right now, I can say that there is a huge dearth of neuropsychologists in tech. And I think we need to find some sort of way of being able to communicate with them in a way that they understand what we do. Because I think a lot of these new companies that are created that I evaluate every day they don't even know that we exist. And so being able to collaborate with them and finding solutions together would be a great step in the right direction. But of course there's risk aversion, and there's also, this idea that we need to recognize that neuropsychology can be innovative without eliminating our traditional trusted measures. And I think this is extremely important in terms of, how we move our field forward. So, what I do is I collaborate with innovators in private companies like Sand Health, as well as academics, institutions. So Sutra Ghosh is a speech expert at MIT. We include speech capture as part of our neuropsych evaluation, and we use speech ecological momentary assessment to determine how things like background noise and changes in speech pattern might correlate with specific aspects of cognitive impairment. Through all of these methods, we can help what I call denoise neuropsychological data. And we can do that by using cognitive EMA. We can do it by looking at proxies of cognition. So I don't think our tests are the only way to measure cognition. We can use something like changes in speech, which has been shown to be able to predict the translation rate between MCI and Alzheimer's disease. We could look at context, like environmental. How noisy is it in a person's everyday environment? What's their psychological state say about their cognition? And we can also use digital technologies that aren't studied typically in the clinic, like face recognition, computer mouse clicks, keystrokes, pressure pads. There's a new startup coming out where they have sensors that go below your feet, and they can predict with pretty good certainty your likelihood of developing Parkinson's disease. So imagine our sort of collaboration with tech companies in that sense and how far we could go. Okay, I'm going to end there. I had a couple more slides, but thank you. And I'd just like to thank all these people, and thanks Know Neuropsychology for having me. I know that was super fast.
Yeah, thank you so much. That was really wonderful presentation from everyone. We have a few questions, so I'll go ahead and start with this one. It says, in 5 to 10 years, what do you believe the future of neuropsychology will look like in terms of innovative digital tools and technologies?
I personally think will look different if we can get buy-in from people who are stuck in their old ways to, really keep the momentum going with, just combining efforts, I think coming together with the work across different research areas, but, to really apply it to the clinic. I think that we could see a shorter evaluation where we can maybe, do a dementia evaluation in 1 hour and be just as good as what we do within 2 to 3 hours. And so I really think that we're going to be seeing more technology. I think digital technology too, or wearables. I think that'll be an interesting interface to collect those data that are showing a lot of promise. But how can we collect things outside of the clinic to also help improve our assessments, and how will that interface with insurance reimbursement and our diagnosing? So I think that we will shorten what we do. We will be able to have better access for people. And so it will rely on multi-institutional collaborations for sure.
I agree with that. And I think that, if I had to summarize, what I think is sort of this integrative aspect, right? Being able to integrate passive monitoring and also be able to provide personalized insights. Because I think right now what we do is we have a lot of passive monitoring tools, right? And we have a lot of data that we collect from our smartphones and from our wearables all day, every day, but we don't know how that might predict cognitive fluctuations in the everyday person. And so my dream is sort of for brain health to be looped into this physical health that sort of our apps and devices are so geared towards currently. currently. And so I think for neuropsychology, understanding how that fits in with our evaluation and what we should keep in our evaluations and sort of room for growth and how we can sort of plug in these different aspects. But I think integration is the key here.
I would agree with everything that's been said in terms of efficiency, personalized feedback, trying to get better measures of actual function in the everyday world. The only thing that I'll add that hasn't been mentioned is using technology for screening of neuropsychological deficits. I think our traditional measures are often not given correctly. They're not given to everybody. They are still time intensive, like in a PCP office. And so integrating technology on that standpoint, I think we can also have more reliability of those measures, but then also reach more people with technology as well.
Yeah, all really wonderful points. We've got just about a minute left. Let's see if we can do maybe one more quick question. Let's see. So all of this in mind, how do you think we can kind of integrate digital tools into neuropsych assessment more practically? Like you said, Laura, the time-intensive process and kind of integrating it more efficiently.
I think we need to show that what we're doing, the changes that we make are good changes and better changes and have better ecological validity. And I think once you have those data and you make it that it's easy to integrate as part of your routine clinical practice, and it's not adding time to your visit to try to figure out all these technologies, but we're going to need training for people as well. So having restructuring our education for our trainees is going to be huge, and having that integrated is going to be necessary for this to be successful. So, I think it's going to be a phase, like multiple phases of integration. But I think that we have to go that way. Otherwise, we're not going to stay relevant.
I don't have much to add to that other than I do think the training aspect, both for current trainees or the current trainees at the time, but then rolling out trainings to currently practicing neuropsychologists is also going to be helpful with that.
And I totally agree with everything everyone said. And just to add, I think that there needs to be some sort of consensus moving forward as well on appropriate tools or a way of assessing which tools are validated in which populations, because I think that's a really big pain point right now in terms of integrating digital tools and evaluations.
Awesome. Well, thank you guys so much for your time. I really appreciate it. And we will see you all next time. This is the last lecture of Volume 6, so stay tuned for information on Volume 7, probably coming up in March. All right, thank you all.
Thanks so much.
Bye. Thank you.